Welcome back,
Good
everybody.
afternoon, everybody.
We are hoping that you are having a good start to your day with us. Before we get this last keynote underway, I'd like to invite a few of our forum partner sponsors to address everyone and give us an update on what they're up to. First up is Eric Levy with Aetna.
Good afternoon, everybody. And we are very excited to be part of the Atlanta Association of Health Underwriters meeting this year. Always a wonderful time to be engaging with everybody. And I think this forum is going great so far. We wanted just to say thank you again for joining and being a participant and let you know some of the new things that we're doing. We have a lot of different avenues for brokers and consultants to view our products for the 2 to 100 segment. Our primary focus is to sell the medical lines for level funded business. We also are selling our dental and vision programs as well. And then we have a lot of robust alternative add-ons that you can put onto your products that come standardly with the Aetna platforms. If you have questions, I would encourage you to please contact your Aetna sales representatives. We have 4 of them in the Atlanta market, and their names are David James, Brian Beatty, Scott Perrin, and Andrew Parker. And once again, we're thrilled to be part of the Atlanta Association Health Underwriters meetings. Take care.
Okay, and next we have our friend Gene Fidel with Adams Keegan.
Greetings from Adams Keegan here in Atlanta. It's great to I guess, kind of see everyone again. I can only see a few folks, but wonderful to be back. I want to thank Atlanta Association of Health Underwriters for allowing us to sponsor again. We've been a long-term sponsor, and things are going very well at Adams Keegan. Thank you very much. I am in my office because the building we're in across from SunTrust Park, there's maybe about 30 cars in the parking lot, so it's a very safe place to be. But Adams Keegan's doing very, very well. As many of you know, and for those who don't know about Adams Keegan, we're an employer services provider that provides a really robust SaaS system, web-based payroll, HRIS, benefits administration, but even more than in technology, we're people doing stuff. So we have HR consultants, benefits consultants, client service managers on my team here in Atlanta. Our offices, our corporate offices are based in Memphis, where the payroll is handled and administered in Central Time. We readily compete with PEOs like Insperity and ADP TotalSource and Oasis and TriNet. However, we do a PEO contract without our own group medical plan. So that's been a real good benefit for our clients that have been using PEOs in the past and have been subject to their one-size-fits-all association plan with one carrier. So you can come to myself or Joe Morrison here as one of my sales folks, and we'll be happy to provide you with our services, a proposal of our services, so that you can approach clients of those PEOs, or if you have those PEOs approaching your clients, feel free to give us a call because we'll help you defend yourself against losing that business. But anyway, one other thing I do want to add, we've been having Friday morning weekly webinars related to COVID, and the attendance at these webinars that occurred at 11 o'clock on Friday mornings has been phenomenal, whether it's FFCRA or PPP or whatever the COVID-19 type of topic du jour, if you will. So if you'd like to attend those, let me know, send me an email, make some contact with me during the sessions here today, and I'll be happy to help you out. Again, it's great to be back. Thank you very much, John, and everyone at AHU for making this process available for us. Again, that's Gene Fidel and Adams Keegan, and if you get in touch with me, I'll give you the Adams Keegan mask. That's very fashionable. Take care.
Oh, it is good seeing some familiar faces, isn't it? Okay, so to kick things off, our last keynote for the day is a representative from the Georgia Department of Insurance, Greg Connolly. Greg is the executive counsel for Insurance and Fire Safety Commissioner John King. Previously, he worked for International Justice Mission, fighting against human trafficking in the country of Ghana. Greg received his JD from the University of Georgia School of Law and a BA in philosophy from Geneva College. A veteran, Greg serves as an infantryman, I know I was going to screw that up, in the U.S. Army, completing 2 tours in Iraq and 1 tour in the Republic of Korea. Greg lives in Atlanta and his German Shepherd Duke. With that being said, I present to you Greg Conley.
Hey everybody, thank you so much for having me. Commissioner King sends his apologies. This week is the week of his wedding anniversary, and he is with his wife in Arizona right now. So, his wife took priority. So I'm going to give you a little bit of a legislative and regulatory update, kind of concentrating on the bills that were passed during the last session, and then kind of where we're at in the stage of passing those regulations, and then I'll be happy to take questions or anything you want to know. So the first kind of big bill, that, at least as far as we're concerned, that's causing us the most work is the surprise billing system. And they titled it the Surprise Billing Consumer Protection Act. And really what this is to protect consumers from going to a hospital, getting a procedure done that they think is covered, and then receiving a large bill later on in which it's not covered. And the bill involves more than the Department of Insurance, but what it's created for us is we have to set a median rate that providers and insurers can look at to decide what is essentially reasonable payment, what's going to be reimbursed for someone who, say, goes and gets an out-of-network charge from what they believe to be a network. One of the big questions we received about this is this just going to apply to anybody who goes to any provider and gets charged out of network? And really the intention behind the bill is more for instance, for people who are going to get an emergency procedure. So you go to the emergency room because you have a burst appendix or something. And then say for instance, one of the doctors who works on you is out of network. Everyone else is in network. Essentially what this bill does is make sure that you're, as a consumer, charged the in-network rate. And then the second part of the mechanism is that there will be arbitration that will take place between the provider and the insurer to decide what the appropriate rate is if there's a large difference. Now, the law permits them to settle, but essentially, if there's going to be a lot of dispute, we're going to send that to arbitration. Several states have done this, most notably New York, Texas, Arizona. And what we've seen from their implementations of the laws is that there has not been a lot of arbitration. There'll be a couple cases throughout the year, but I think Arizona in their first year had 15 arbitrations, which is not a lot in comparison to the number of disputes you're going to have over claims. So that's kind of in short, what the Surprise Billing Act does. They've also created what's called a surprise billing rating system, which actually went into effect or will go into effect on 11/1. And what that is it requires insurers to show how many of the groups in a particular hospital are in network or out of network. The law is written a little vaguely, and so we're working on trying to figure that out. Although it goes active on November 1st, we're not going to take any regulatory actions with respect to the rating system until after January 1st because it's a little too rushed for us to be able to get regulations down in time. I think I should mention at this point, the timeline for new regulations for all bills that were passed in the past session is that we're in the process of drafting. The drafting should be completed by the 1st of October, at which point I will schedule the hearings. Tentatively, November 10th is the date we're looking at for a hearing. But when I schedule the hearings, all the regulations will be released for public comment. And so then you can email us or call us or whatever and let us know your thoughts. The hearing will be public. I don't know, based on where the world is right now, how exactly that public will work, if it'll be via Zoom, in person, maybe a mixture of both. Once again, people have a chance to comment on every regulation we pass. And the timeline was created in that manner so that we would have time to reevaluate any regulations that need tweaking and then get them to the Secretary of State's office so they could be active January 1st when the laws go into effect. Some of kind of the little bitty laws we passed that really benefit us, but not necessarily anyone outside, is we passed a special fraud fund assessment to once a year. Our fraud department is funded by carriers, and they're assessed based on their premiums written every year to fund the fraud department. And we were supposed to assess them twice a year, or maybe it was quarterly. and then they would pay the amount quarterly. Well, no one did that. We assessed them once a year. They paid us once a year. And so we kept getting in trouble with the Department of Audits for not following the quarterly assessment. And so since it made no difference to the amount of money we collected, the carriers wanted this done. We wanted it done. It kind of made things easy. We also moved to elevator inspections once a year as opposed to twice a year because we don't have the staffing to do it twice a year. And frankly, safety really demands that we only do it once a year. One of the other things, other big bills that we passed that probably didn't cause a lot of public comment, but we were very happy with, was changes to the guarantee fund. One of the major concerns industry-wide and frankly nationally amongst insurance commissioners is the state of the long-term care market. I'm sure some of you might be familiar with Penn Treaty and that company going insolvent. Right now we're dealing with the State Health of Pennsylvania, SHIP for short, which is right now being dealt with in Pennsylvania. There's a question as to whether it's going to go into receivership or be declared insolvent. But ultimately, over the next 10 to 15 years, it would appear that a lot of long-term care companies are going to go insolvent, or at least require serious receivership. And so the guarantee fund was, a law was passed here, and it's going to be passed around the country to anticipate this. And what it does is it includes more insurers in the pool giving into the guarantee fund. So life insurance companies are now included, and HMOs are now included, which means that if you're an HMO customer previously and an HMO went insolvent, you weren't going to be covered by the guarantee fund in the same manner you would now. So it actually adds more security. And it was really an industry initiated thing. We loved the idea, but the industry was also very happy about it. And frankly, the insurers came together and realized, this is an issue we're going to have to pay for sometime in the next 1 to 2 decades. And so it's better to expand the guarantee fund now to prepare for that, which I think is going to, in the long term, is really going to pay off. And once again, it was not something that maybe the public was necessarily aware of, or a bill that caused a lot of drama, but it was extremely important in terms of the long care health of the Georgia market. Some other things we saw is there was a peer-to-peer car sharing insurance bill passed, which essentially allows peer-to-peer vehicle sharing programs and insurance requirements that go along with that. It doesn't really impact us very much. It just simply permits these things to take place in insurance to be written. So we'll simply regulate the insurance that's being written on those programs, as they come in. There's also a small bill, House Bill 716, which related to carriers issuing health benefit plans to pay insurance agents commissions and gives us some type of regulatory authority. Essentially, it means that my understanding from the bill, and this was not a bill we passed, this is just a bill somebody told us this impacts you, is that during open enrollment, the insurers had to pay commissions. Now they have to file with us what those commissions are. We're still kind of working through whatever regulations we may need to pass with respect to that, but we haven't really come down too hard right now because we have several other bills that are kind of a larger and require more work, which is a good segue into the new pharmacy benefit manager regulations. This is also a large bill, one that we did not initiate. We didn't pass it, but we had some hand in the way it made its way through the legislature because it put a lot of responsibility on us, and we wanted to make sure we were able to properly enforce whatever rules they gave us, which really comes down to the examination function that this adds. So pharmacy benefit managers, last January, a law went into effect, which allowed us to regulate pharmacy benefit managers and put some teeth into if they violate our regulations. We're allowed to fine them per violation at certain amounts. But this bill kind of expanded even more. And so what this allows us to do is examine pharmacy benefit managers in the same manner we would examine any admitted lines insurer. So it would be we would hire a firm and do a significant look at their finances and kind of their practices. That also came with some changes. There was a separate bill passed that came with the Pharmacy Audit Bill of Rights, which doesn't really impact us very much, but it was sort of a hand-in-hand bill. Another bill that came across was the criteria, Senate Bill 28 created criteria for co-payments in certain health plans. What this really did is it prohibits certain insurers from imposing co-payment, co-insurance, or office visit charge in an amount greater than such charges imposed for physicians or osteopath services to an insured for services rendered by a physical therapist, occupational therapist, or a chiropractor. So essentially, it kind of evens out the co-payment structure amongst kind of those disciplines. The Georgia Right to Shop Act was Senate Bill 303, and it provides for greater transparency of prices for non-emergency healthcare services. This does not involve our department very much. It sort of puts all the onus on insurers to make a lot of data available to the public on their websites and through different types of documentation. We're tasked with defining certain terms, and once again, we're in the drafting period right now, so we're still working on those. We also passed an early prescription refill during Emergencies Act, and what this did was, for instance, in the event of a hurricane, this gives people the ability to go to their pharmacy and get 30-day supply of their prescriptions without having to go get a new prescription from their doctor. It does carve out opiates and things of that nature, but it's something they did in Florida. It's something we've seen in other states that deal with natural disasters on sort of an annual basis, and so we thought that was a good thing to do. And finally, there's supposed to be an all-payer health claims database, which is a big issue that came up in a lot of bills. And ultimately, initially, that was supposed to be our sole responsibility. But when we sort of walked through how complicated and how expensive that was going to be, the legislature passed Senate Bill 482, which created an advisory committee for the all-payer health claims database. And so that's going to be located at, I believe, in concert with Georgia Tech. And then there's a bunch of appointments onto that board that's going to kind of oversee that database. And so that's where we are in terms of the laws that were passed last session. One regulation that may not impact you, but or two sets of regulations that may not impact you, but you might want to be aware of. Industrial loan was moved out of the department in the last session, and so as of, I believe, August the 1st, or perhaps July the 1st, we moved our industrial loan department to banking and finance. And so they're no longer part of us. Our only regulations, our only involvement with industrial loans now is the insurance policies that are written in conjunction or on industrial loans. The second regulation that we passed was one having to do with Form A proceeding. So when one insurer acquires another insurer, you have to submit a Form A statement, and we evaluate the finances. Essentially what we had happening was large investment companies like BlackRock, Vanguard, Raymond James, things like this, were acquiring holding companies that contained a Georgia domestic insurer, but were either unaware or the domestic insurer was so minor they did not know. And the idea of Form A proceedings is that if someone's acquiring an insurer with the intent to sell insurance, we want to check whether, how much debt they're taking on, the effect it's going to have on the market, things like this. And these companies are not acquiring holding companies because they want to sell insurance. They're acquiring them because they're trying to hit a certain index in a specific portion of the market. And so we passed a regulation that allows companies who are doing that to get an exemption from sort of the more onerous Form A requirements if they can be termed a passive investor. And passive investor is something that's defined by the Securities and Exchange Commission, and so we're kind of piggybacking off their definition. And so we're kind of trying to make it a little more, make things a little more business friendly, especially for large institutional investors. So that's kind of been the latter half of this year in terms of legislation and regulation. As in terms of what we see coming next session, I think the one thing everyone's asked us about is network adequacy. network adequacy is not something that right now we have a big hand in. It's not something we evaluate. It's not something we're really equipped to evaluate. We don't have the individuals on staff. But it's something that was a bill that was introduced last year to talk about network adequacy. And I would anticipate it being introduced again. And really what this does is it's a law that allows us to look at insurers in certain markets as they're pulling in and pulling out, or they're removing providers or adding providers. Is their actual network offering adequate enough that consumers are actually being covered? And that can kind of take a lot of different forms, but that's essentially the focus of the idea. And so that's probably the largest thing we see happening legislatively in the next session. The waiver, the healthcare waiver project has been pushed off, has been delayed for approval until next year. Originally, we'd anticipated getting from insurers their rates that they would charge based off of the waiver that was submitted this year. But once that was pushed off, then we just took their ACA anticipated rates on the same timetable we would any year. So that's sort of where we're at in terms of legislation and regulation at the Department of Insurance. I'll be happy to take your questions about that, about any questions you have about specific bills, or about what's coming up, or about anything we're doing at the department.
So if anybody has any questions they would like to ask, please enter that in the chat. We'll give it a couple seconds to see if we get any hits. Okay, so if anything else pops up, I'll stop mid-sentence, but I guess that might just be it. Thank you very much for your presentation, Greg,
Sure.
and for the updates from our insurance department. I understand that our Commissioner, John King, has been a great partner for our friends at the Georgia Association of Health Underwriters. So I'd like to thank him for sending us his best to speak to our members. Oh, here's one. Can you go into detail regarding PBM legislation?
Sure. I don't know if there's a specific bit of detail you'd like, but I can kind of walk you through, I guess, kind of what it does. So let me pull up my bill for you right here. So what this law was essentially, one of the big things that the legislature was attempting to get away from was something called steering. And that's essentially where an insurer says, you have to use my pharmacy, and essentially pushes consumers off. I wanted to give consumers choice. So what this really does is, so it forces pharmacies, pharmacy benefit managers to, follow certain business practices. So one would be steering. And so a physician employed by or contracted with a pharmacy benefit manager advising on or making determinations specific to a Georgia insured in connection with a prior authorization or step therapy appeal. If you're not familiar with step therapy, so essentially there's sort of like two different steps that the insurer is going to take to improve the medicine. This sort of pushes that to the side absent certain specific situations. So if you're a physician and you've actually seen a patient in the last 5 years, and you've been continuously working with them, you can sort of skip over kind of the step therapy appeal. It gives us the power to essentially go after look at pharmacy benefit managers' economic modeling and also their financials. So they have to use the national average drug acquisition cost as a point of reference for ingredient drug product components of a reimbursement. And we're able to take a look at that, and it can also be applied to the public. So what does that mean? So pharmacy benefit managers, to put it simply, are middlemen. They contract between pharmacies and between insurers, and they make a lot of money doing that. And so part of the issue is that what a insurer says that they're paying for something via a pharmacy benefit manager is a list price, right? And the list price changes pretty quickly throughout the year, depending on kind of the deals that they're getting. But the list price or the list cost and the actual cost can be very, very different. And so what this is doing is it's requiring them to use the national average drug acquisition cost list as a reference point for reimbursement. And so that actually gives us power based if they're reimbursing above or below, too far or above or below the national drug acquisition price to take some action. They can't discriminate in reimbursement, assess any fees or adjustments, or exclude a pharmacy from the pharmacy benefit managers network that on the basis that the pharmacy dispenses drugs subject to agreement under Medicaid or Medicare laws. They may not. They can't base reimbursement for a drug on patient outcomes, scores, metrics. They can't impose a point of sale fee or retroactive fee. This is all as of January 1st of this coming year. They cannot derive any revenue from a pharmacy or insured in connection with pharmacy benefits management services. They can. They also have to, they have to offer health plan the ability to receive 100% of all rebates it receives from pharmaceutical manufacturers. So essentially what that means is pharmaceutical manufacturer says if you buy this bulk cost or bulk shipment of pick the drug, you receive a rebate. So what they're doing is the pharmacy benefit manager keeps the rebate and the health plan pays the full cost. And so now they have to offer the health plan the ability to receive all the rebates they get from manufacturers. The idea being that will lower the cost to the health plan, which will also lower the cost to the consumer. Also, PBMs have to offer the health plan the option of charging the health plan the same price for a prescription drug it pays a pharmacy for the prescription drug. So what they can do, essentially being that whatever they're paying the pharmacy, they can now the health plan can now know. So they'll know the difference if the pharmacy is paying a low cost and the health plan is paying a high cost. That's sort of all money that's going to the pharmacy benefit managers. The idea is to take that money out of their hands and hopefully back into the consumers. They also have to report to health plans the difference between the amount the pharmacy benefit managers reimburse the pharmacy and the amount the pharmacy benefit managers charge the health plan. Once again, seeing if there are large disparities. That kind of stuff is confidential. So the department can get access to it, but it's not available to the public. So also when calculating the insured's contribution to any out-of-pocket maximum deductible or co-payment, pharmacy benefit managers have to include any amount paid by the insured or paid on his or her behalf through a third-party payment program of any kind. So also, pharmacy benefit managers have to offer or can't prohibit you from looking after or going after the generic equivalent drug. So, and they define pretty well what a generic equivalent, but essentially they can't charge you more for the name brand or force you to take the name brand because it costs twice as much and then they make more money out of it. In terms of what it gives our power, the department the power to do is we can license, or we have been licensing, but to raise the fee for licensing and for renewal for pharmacy benefit managers. And it allows us to fine them $2,000 per transaction for any pharmacy benefit manager without a license. And if they knew or should have known they were in violation, we can charge them up to $10,000 for every violation. Additionally, in the event that they violate the law in any way, we have the authority to suspend their license and then also examine them. And that is sort of we can conduct financial examinations, compliance audits, and this is, it doesn't extend to the state health benefit plan, but it does extend everywhere else. And so that kind of gives us the same power we have over insurers. And that's, so I know it's kind of a dry subject, but that's sort of the a 10,000-foot level on the legislation. I see you got a couple more questions here.
Yeah, and he mentions drug reimbursements for PBM tends to be very high when an insurer owns the PBM and is essentially buying from themselves and counting as a claim against MLR. Legislation to help consumers with this is greatly appreciated. Copay plan enrollees are often protected by low copays, but high deductible health plan members often find their insurer charges them $75 for a drug that they can get through GoodRx. So follow-up question, does the waiver of step therapy for a patient with a long-term physician relationship apply towards Part D plans with Medicare?
I do not think that it does. I think that we are stopped from doing that because it's because of the federal involvement. But I will take another look at the law. But I don't think we can step in there. Yeah.
Okay, if there are any other questions, we are willing to read them out loud, see if we can get a response. Okay, so again, if someone types something in, I'll stop mid-sentence, we'll hop right back into it. But unless that happens, thank you so much, Greg, for your time, for your expertise. As I was mentioning, John King has been great working with Georgia, the Georgia Association. So we'd like to thank him again for sending you our way. If you can send him the good word on our behalf when he gets back from his trip, that would be greatly appreciated. And I hope he understands that if your department wants to know what's actually happening in the trenches with our clients, he has a resource at his disposal with quite literally all of us. That'll pretty much close out things for today. The breakout sessions with our sponsors will remain open for a little while longer after this keynote ends. And if you would like to stick around and visit our partners, you should have the capability to do so if you couldn't do it earlier. Again,